osis is a rare systemic disease caused by deposits of amyloid protein fibrils in one or more organs, causing the organs to malfunction. It's a very rare disease. Only about 1,200 new cases are reported each year in the United States. 60% of those cases are men, typically over the age of 60. Both the causes and the origins of amyloidosis remain poorly understood. There is no known cure for amyloidosis at this time, and treatment is centered on reversing the deposits of amyloid. Primary amyloidosis is an acquired plasma cell disorder in which a monoclonal immunoglobulin light chain is produced in the bone marrow and usually found in the blood or the urine. Most protein cells make the whole protein in one piece, but others make protein fragments, which are at risk of misfolding when they are synthesized. These misfolded proteins usually dissolve, but for unknown reasons, in amyloidosis, these proteins are spit out to form aggregate oligomers. These insoluble oligomers stabilize into fibrous protein aggregates known as amyloids. The amyloid fibrils make up immunoglobulin light chain proteins kappa or lambda and are deposited in the extracellular space of various organs or tissues, disrupting normal function. Both the oligomers and the amyloid fibrils can cause cell toxicity and organ dysfunction, affecting the major organ in the body, and can cause symptoms such as heart failure, protein in the urine, kidney failure, enlarged liver, neuropathy, and enlarged tongue. Signs and symptoms. Symptoms of underlying chronic disease processes often mask the signs of amyloid deposits. Patients can exhibit symptoms such as slow onset of unexplained protein in the urine, unexplained kidney failure, enlarged liver or spleen, malabsorption of food, nerve damage. Amyloid deposits in the gastrointestinal system, for instance, can cause symptoms ranging from nausea, vomiting, severe GERD, and unexplained gastrointestinal bleeds. Amyloidosis affecting the pulmonary system can cause sustained infections such as pneumonia, pleural effusions, and even pneumothorax. Cardiac involvement may present initially with an abnormal EKG suggestive of prior heart attack or ischemia. Also, patients can experience pericarditis and then congestive heart failure. Diagnosis confirmed. The diagnosis of amyloidosis is often delayed because the signs and symptoms can be varied and affect multiple organ systems. It takes an experienced physician team to pull together the possibility of amyloidosis and order the correct diagnostic tests. If amyloidosis is suspected, a tissue sample of the abdominal wall can be examined in biopsy for evidence of characteristic amyloid proteins. This is called a fat pad biopsy. The tissue is stained with Congo red stain, which combined with polarized light makes the amyloid proteins appear apple green on microscopy. This type of biopsy has been shown to be 80% effective in diagnosing amyloidosis. In addition, the patient can be examined for plasma cell dyscrasia by immunofixation electrophoresis of the blood and urine, along with bone marrow biopsy with immunohistochemical staining of plasma cells for CAMDA and lambda light chains. Treatment. There is no treatment to date that specifically promotes the clearance of amyloid deposits. Current therapeutic strategies are centered on reducing the supply of the amyloid fibril precursor protein while supporting or replacing the functions of affected organs. Stem cell transplant combined with high-dose chemotherapy remains the treatment of choice for those patients that qualify. The thinking is to try and eliminate the blood plasma cells in the bone marrow and then regrow the bone marrow using the patient's own stem cells. Patients must have extensive testing prior to transplant to ensure they are otherwise healthy enough to withstand the procedure and verify there are no amyloid deposits in their cardiac system. Cardiac involvement has no known treatment options at this time. There are multiple other chemo-type treatments available depending on organ involvement as well as ongoing clinical trials. Prognosis. The clinical course of amyloidosis is usually associated with rapid disease progression and involvement of multiple organs, making the survivability rate poor for most patients. The majority of patients survive 3 to 4 years after initial diagnosis, but those with cardiac involvement unfortunately have only a 6 to 9 month expected lifespan. Survival depends on how soon after the onset of symptoms treatment is started, the aggressiveness of the disease. It does seem to vary from individual to individual, which body organs are involved and to what degree, and the age and general health of the patient at diagnosis. Patients receiving the high-dose chemotherapy with stem cell transplant have the greatest survivability and can anticipate the best prognosis for this often terminal disease. These patients must continue to be monitored closely for their lives. They may require further treatment, including chemotherapy and even additional stem cell transplant. In 1966, a young soldier left Fort Worth, Texas, headed for Vietnam. He fought in the jungles and in the trenches, and he kept helicopters flying. But he also did one thing else. He handled Agent Orange. In 1968, he came home. During the Vietnam War between 1962 and 1971, the U.S. military sprayed nearly 20 million U.S. gallons of chemical herbicides and defoliants in Vietnam, eastern Laos, and parts of Cambodia as part of an aerial defoliation program known as Operation Ranch Hand. Mechanics who worked on the helicopters and airplanes during this period of time are said to have some of the greatest exposure to the chemical Agent Orange. While in Vietnam, the veterans were told not to worry and were persuaded that the chemical was harmless. But after returning home, Vietnam veterans began to suspect that their ill health or their instances of their wives having miscarriages or children born with birth defects might be related to Agent Orange and other toxic herbicides that they were exposed to in Vietnam. No one will ever know for sure, but 1 week before the diagnosis in November of 2008, the VA made amyloidosis a presumptive disease for receiving veterans' benefits for exposure to Agent Orange. In November of 2008, a 63-year-old white male presented with a history of gastrointestinal bleed, unknown etiology, history of 2 prior pneumonias within 12 months, both resulting in pneumothorax, both resulting in pleural effusion needing thoracentesis, 1 incidence of pericarditis. He complained of severe fatigue, muscle aches, and unexplained elevated urine protein levels. Luckily, working for a physician and having a daughter that is an RN did help expedite the diagnosis. Our daughter had recently taken a position with Texas Oncology as an oncology certified RN. Diagnosis was soon made, after a fat pad biopsy was taken, and we were given the news that he had confirmed amyloidosis. It was very soon after that we were told that our options basically were to have a stem cell transplant, that it was the only viable option for someone with his condition, his age, and his stage of disease process. In January of 2009, we made our way to Baylor, Dallas Transplant Unit, where he was admitted on January the 11th, 2009.